Thank you, everybody. And I'm going to go ahead and mute myself so we can welcome our presenter. Thank you.
Hi, everybody. Thank you so much. I am going to be your presenter today. I'm going to give you a little bit of information about myself, and then we're going to get started. My name is Sarah Kallio. I'm an associate professor of psychiatry, and I run the Arizona Psychiatry Access Line, Perinatal Psychiatry Access Line right now. And hopefully in a month, I'll have a pediatric psychiatry access line as well. So hopefully we can come back to Project Echo once we have that launched. Today, I'm going to be focusing on perinatal mood and anxiety disorders. So we're going to talk about sort of the prevalence of the disease and think about the consequences of untreated perinatal mood and anxiety disorders and do a quick overview of the medications. And we might kind of pull, in terms of how much depth we go into, we'll play it by ear. And in terms of when you're thinking about Project Echo, you have to kind of frame it in a case as recommended. And part of the reason I didn't pull a cases was I was going to challenge you all to think about a person, right? Somebody in your life that has been pregnant. So that could be yourself, your significant other, your sister, your aunt, somebody you know that had recently been pregnant. And think about them as we go through these considerations. And I'm going to challenge you to assume that they're struggling with anxiety disorder or mood disorder, et cetera. Part of the reason I'm doing this is because this will help you all come up with sort of diverse examples and more inclusive sort of a case than I could come up with for myself. And I'm hoping that you will challenge and question as we go through of like, what would the racial considerations, ethnic considerations be as we think about this data set as well. Additionally, I'm going to go through some considerations that happen, physiological considerations and psychological pieces of pregnancy. And sometimes when you think about them for somebody you know and care about, they become more palpably real and memorable. So I'm hoping that'll stick with us as well. So when we're talking about the perinatal period, this is sort of the time frame from conception through the first year after giving birth. That's kind of the classic definition. This becomes kind of a challenging consideration when you're thinking about it from a psychiatric framework, right? So when you're thinking about it in terms of how long postpartum can you struggle with mood and anxiety disorders or sequelae from giving birth, then that's a much longer definition. We're going to stick with sort of the American College of Obstetric and Gynecological considerations. And this is the time frame we're thinking about, that 1 year, first year after giving birth. And a lot of fluctuations will happen, right? Hormonal fluctuation, lactation, onset of laxation, weaning, reemergence of menstruation. So all of these things will happen. So now I want you to hold that person in mind that you were thinking about in terms of who is this pregnant person that we're going to think about. And let's think about all the physiological changes. And for those of you that are thinking about yourself, great. Because I think sometimes we don't think about all the changes that we go through in that time period. So as it comes to physiological changes, obviously weight gain is a big one. We all know about this in pregnancy, but the recommendations of what sort of the accepted weight gain in pregnancy is have kind of shifted. So it can be anywhere from 22 to 36 pounds. So it varies in terms of what the norm is. Sleep is its own problem. To the requirement that the American Academy of Sleep, the American Sleep Academy has designated a sleep disorder that is specific to pregnancy because there's so much sleep disruption. Up to 66% of women will report disordered sleep. So forget about the idea of like affected sleep, because we all know, of course, your sleep's going to be affected. But sleep is a really, really huge deal when we think about mood stability, resilience, memory, function, and just accepting that everybody's sleep is just going to be poor is not okay. The endocrine system, and it's so nice to be able to put the endocrine system in 2 words and say, of course, there are endocrine system changes in pregnancy. There are multiple endocrine system changes in pregnancy. I think automatically everybody thinks estrogen, progesterone. But it doesn't limit to that. Thyroid function changes significantly during pregnancy. But let's dive into one system. So adrenal system. So your adrenal system is going to have massive changes in pregnancy. By the end of pregnancy, the level of total cortisol is nearly 3 times that of non-pregnant values and sort of sit in the levels of Cushing's syndrome, which is a pretty horrific change, which we're like, adrenal system, endocrine system. And I'm bringing all of these up one by one so that as we all take care of patients or are present for our people in our lives who are pregnant or struggling with sort of scenarios, that we normalize some of the massive shifts that happen during pregnancy as well. Cardiovascular system. Your heart is physically displaced upwards and leftwards during pregnancy to the point that eccentric cardiac hypertrophy is common. Like we're like 30% of people will have some level of cardiac hypertrophy. The other thing, actually, no, it's not 30%, it's 10%. The other thing that will shift in terms of cardiovascular system is your cardiac output will get upregulated by 30 to 50%, which is a huge shift from preconception to in pregnancy. Hematological system, you are hypercoagulable. So by 5 to 6-fold. These are massive shifts in every single system that I'm talking about. Respiratory system. The respiratory system is twofold that annoys me. One of the things that bugs me really when it comes to the respiratory system is edema. So your nasopharyngeal mucosa just pulls in more and more fluid. So you're just uncomfortable and sniffling the entire time. And that's just part of the shifts that happen. We have progesterone to thank for that one. And then the other one is reduced total lung capacity. So now the things that I'm talking about for this person that's in your mind, they have gained weight, they can't sleep, their cortisol levels are increasing significantly to disease states by the end of pregnancy, their hearts have shifted, their total lung capacity has decreased, they're more likely to be hypercoagulable, they can't stop sneezing, and they have a lot of snot, and we haven't even gotten to the GI system and the persistent nausea. And I really want you to kind of think about this is just normal. And sometimes we tend to struggle when it comes to mental illness and psychiatry in terms of normal. And there's a big critique of psychiatry of like, we tend to medicalize dis-ease. So we tend to say normal stuff is a disease state when it's not. And I want you to think about what we call normal and how sometimes normal can also be a really stressful space to be in. I've only talked about physiological changes. Psychologically, of course, this is quite a distinct space in itself in terms of preconception. Am I going to get pregnant? What's going to happen? Is it going to work out for me or not? Or I am pregnant. And in the event of, actually, let me bring the psychological spaces back in a different way. When a woman birthing person goes through this journey of wanting to have a child or getting pregnant, you basically come across every single thing in our society that's a challenge. For example, getting pregnant. So infertility management, who gets care, who's able to qualify for those services or not, depending on whether you have insurance and how expensive is it going to be. So the healthcare challenges. So you do get pregnant. Then you're faced with reproductive choice. Do I want to have a baby? And is that my choice in terms of what to do? So that's another big challenge that you're coming up with. Then you come up again with the healthcare system of like cost of it, who's going to take care of it, how far is sick care, then birth in itself in terms of postpartum care and how long am I covered. Thank God Arizona has Medicaid coverage now up to a year, which is great, but not every state in the US does. So that healthcare coverage is an issue. Family parental leave, and that's a challenge in terms of can I afford to take time off to stay home with my baby? If I can't, then I have to go back to work. And if I do go back to work, childcare is super expensive. And once childcare, say you're past that, and then schools, quality of education, school safety. So you're hitting a lot of these spaces, things in your journey of parenthood, pregnancy that are really, really big social issues as well. And that has psychological sequelae. So if I haven't lost you all completely and I haven't scared you all off of pregnancy, let's go to the topic that I want to talk about, which is the perinatal mood and anxiety disorders. And in terms of why I want to talk about both perinatal mood and anxiety disorders is because a lot of the times when people say, I have postpartum, they are referring to postpartum depression. And frankly, postpartum depression is the second most common post sort of perinatal psychiatric disease. The first most common is anxiety disorders. And I think part of, and this is just me going on a tiny tangent, and you guys can tell me in the chat if you agree with this idea or not, is I think we tend to just normalize anxiety in women. We're like, of course you're stressed and you're worried and you're restless and you're anxious. So we kind of dismiss anxiety, but perinatal anxiety disorders, and I mean clinical illness, is actually really, really prevalent. So up to 20 to 22% pregnant of women will have it. So that's why we've changed sort of the terminology from what it used to be, which was PPD, which was postpartum depression, to perinatal mood and anxiety disorder. So we're bringing the focus back to this can happen early in the pregnancy as well, and of course can continue through that postpartum period, and it's mood and anxiety disorders as well. They are highly, highly prevalent diseases. So perinatal depression affects 1 in 7 women. And part of the reason, and I'm sorry I should have done this disclaimer earlier, but a lot of the terms I'm going to be using today are going to be heteronormative. So I'm going to say women, man, dad, father. And part of the reason I'm using that is the data that I'm quoting. So we don't have inclusive data sets in terms of yet. And so that becomes a bit of a challenge. So I'm trying to stay true to the data sets that I'm quoting. So perinatal depression affects 1 in 7 women. We assume that it applies to all birthing persons, but that's the data set we have. The other thing is if I were to expand that data set and say perinatal mood anxiety disorders, perinatal mental illness to include ADHD, include substance use disorders, that number becomes 1 in 5, which is a really, really high number in terms of the amount of impact of it. So when you think about, say, things like gestational diabetes, that's like 7% of pregnancies. Here we're talking about up to 22% of pregnancies with actual clinical illness, not baby blues, not stress, illness. The other thing to keep in mind is that 1 in 10 dads are affected by postnatal depression. So mothers being depressed has a consequence to their partners and significant others. Specifically, the data set said dads. I'm extrapolating it to significant other spouses, partners. So that's a pretty high risk factor as well. And in a minute, we're going to talk about sequelae and like, why do we care if everybody's depressed, right? Maybe that's just the new world we're in if you listen to TikTok, which please don't. So we'll talk about that as well, but I want you to think about this person and coming back to this person that you're thinking about and think about how high of a risk that they're at. And while we'll talk about sort of the considerations and sequelae for this disease, for the baby and the mom, that's just no way to live. Also, depression is it's not the absence of joy, it's the absence of contentment. And we really want families in Arizona and of course everywhere to have a good sort of start to life, everybody to go well. When you think about the amount of births in the US, which is what, like 4 million births in the US, this is 600,000 families that are getting affected by perinatal mood and anxiety disorders, which is huge. According to the official journal of the American Academy of Pediatrics, they also noted that more than 400,000 infants are born to moms who are depressed, which is the most common undiagnosed obstetric complication in America. So that's a lot of depressed parents and infants born to depression, which is also a challenge. There's an old myth where we tell people that like it's going to be a great time, it's going to be such a wonderful, joyous time, and please be so blessed. And that's just not true. And I think while some of the stigma is falling away, maybe that stigma hasn't fully fallen away, especially when you think about the whole spectrum. So not just the mom, but also the impact on the significant other. So thinking about that scenario, and we'd never be like, oh, it's going to be great to come off of meds if it was like diabetes. And so I think thinking about it in sort of that frame of how conversations happen and how stigma plays a big role when it comes to people struggling with mental illness. So let's come back to Arizona for a second, right? So when you think about Arizona, almost half of all pregnancy-associated deaths in Arizona were related to mental health conditions. So this is 2016, 2018 data from the Arizona Department of Health Services. And that is a very, very high number. So for Arizona's pregnancy-associated deaths, almost half being associated with mental health conditions is a pretty serious thing. There's also a notable disparity when it comes to Arizona in terms of who gives birth and who struggles with pregnancy-associated death, which is attributable to mental illness or substance use disorders. So for example, white patients are responsible, white women are responsible for 43.5% of Arizona's birth, but significantly higher number in terms of pregnancy-associated deaths due to mental health and conditions. I really want to draw your attention to the American Indian and Alaskan Native population. So while they have only 5.9% of live births, it's almost double that in terms of pregnancy-associated deaths. So it's a pretty high number in that scenario, which is not surprising. So when you look at national data, Black and Latina women are 33 times more likely to experience a perinatal mental illness than white women. And there's a bit more to that consideration. So when you look at the CDC's history of tracking maternal mortality throughout almost 100 years that they've been tracking maternal mortality, the entire time, maternal mortality for African American women has been notably higher compared to white women. So it's been a long-standing issue that we've known about that hasn't changed. The one thing I will point out is when you look at things like considerations for postpartum depression in, say, African American patients, they are at increased risk of developing postpartum depression, but also to have more severe postpartum depression and have delays in referral to care, which also means that they're going to take a while to recover from it as well. So this kind of stuff in terms of how it sets up for generational trauma, et cetera, is really, really important. For those of us that have to sit and talk to advocates, lawmakers, policymakers, not everybody will respond to the same sort of emotional appeal of like the impact of this disease. These are also very expensive diseases, right? In terms of having the cost of it. So cost of it, when you look at cost data, and this is hard when you look at psychiatric data, partly because it's really hard to say this is going to be the cost because of X, Y, and Z. So this cost data is a mathematical paper. They looked at cost entirely due to increased cost of medical care, inappropriate medical care, child abuse, neglect, discontinuation of breastfeeding, dysfunction, and sort of all of that scenario, which is really hard to account for cost for that. So some of these papers will just look at cost due to inappropriate medical care and sort of hospitalizations, et cetera. So this $14.2 billion is looking at medical care and in discontinuing and sort of hospitalization, et cetera. When you kind of lower that down further, that untreated dyad of mom and baby costs us $32,000 a year. This is 2010 data, so I'm assuming it's more expensive now. This would apply to about 20% of births in Arizona. So Arizona has about 78,000 births. And so 20% of those births is 15,600. Those of you that are quick with a calculator will say that it's lower, it's higher than that $375 million cost. It actually comes out to about 400 million. That's because I really wanted to feel better. And I assumed that 5% of these patients got treatment, which is what the data says. So assuming some of these women got identified and got treatment, this still costs Arizona $375 million a year. So yes, that's significant cost that we care about. The other costs that we care about are sort of risks and sequelae of untreated disease. So this is going to cause relationship problems. This is going to cause poor adherence to medical care. This is the mom that's not showing up to postpartum appointments. This is going to increase disability, unemployment, intimate partner violence is a big one, divorce, loss of financial resources, increased drug, alcohol, tobacco use. I'm not making this up. This has been researched. And so this has got significant scenario. And that's the issue when it comes to health and illness in general, right? It creeps into your life, affects various aspects of your life. And not in mental illness, it affects not just your life, it affects the lives of those around you. The other piece, of course, as we discuss, the consequences in racial and ethnic minorities, there's a higher burden of disability sometimes. And then even though rates of depression might be lower, the sequelae is higher or the persistence of that is higher as well. Additionally, I want you to kind of pay attention to this. People who identify as as being two or more races are more likely to report any mental illness than any other ethnic group, which given our sort of population in Arizona, something to keep in mind. Risk factors for perinatal depression. Again, think back to that person who you identified in your head, the case in your head, and see what risk factors may be applied to this person that you're thinking of. Maternal anxiety, history of depression, unintended pregnancy. And I'm going to come back to sort of contraception and unintended pregnancy in a bit. Cliffhangers to keep you awake during lunch hour. Intimate partner violence and lack of social support. Medicaid insurance is its own risk factor. Low socioeconomic status, smoking, single status, unsupported relationships, and adolescent mothers. Oh, fun fact, in terms of unintended pregnancy, in Arizona, the US number is like 48 to 50% of pregnancies are unintended. Arizona's number is a little higher than that, so we cross 50%. But also if you're looking at unintended pregnancy by age bracket, we have slightly higher than national rates for adolescent moms. So something to think about in terms of risk factors and where our state lies for ourselves. For postpartum depression, similar-ish risk factors, of course, but then you add in sort of the experience of pregnancy and then birth, right? Depression during pregnancy, anxiety during pregnancy, trauma during any early pregnancy, traumatic birth, preterm birth, NICU admissions, and a big one, breastfeeding challenges. So breastfeeding is associated with doing well in breastfeeding, and it going well is great because it's almost helpful in terms of helping the mother ground and actually being very positive on their mental health. But if it doesn't go well, it's actually an independent risk factor for postpartum depression or anxiety. So having moms feel like they can come to somebody and be supported, which is why IBLCs are some of my favorite people, because they have such a quick, lovely impact on that mom's mental health and really sort of the family's care as well. So why do we care in terms of why do we care about sort of the pieces in the sequelae of these diseases? It has poor health behaviors. So this is a mom with poor prenatal care, has poor nutrition for herself, has increase in tobacco and drug use, but also this person is more likely to have pregnancy complications, nausea, vomiting, preeclampsia. Antenatal depression, which I should have put on the slide, is associated with higher rates of obstetrical complications, right? Which is, of course, what preeclampsia is, but including operative delivery, which nobody wants an operative delivery, I think. And then, of course, impaired bonding and maternal suicide. Maternal suicide is also something we should just stop for 30 seconds on. When it comes to maternal suicide, I think there's some idea that people think that this is going to happen quickly. Most of maternal suicide occurs 6 to 9 months after birth. And that makes sense when you give it a second to think about, right? Like that initial amount of attention and stuff is gone. People are like, oh, well, you've had a baby. And so life is supposed to go back to normal. And that idea of like things are going to get better maybe floats away. And that's another reason this Medicaid coverage lasting up to a year is such a big deal. So having Arizona be one of the states that does it is going to make such a big impact in terms of our follow-up for moms. Because if they didn't have care, how are they going to, if they didn't have insurance or coverage, how are they going to access it? In terms of impact on baby or fetus, because we all care about the baby, and sometimes that's a big motivator. But I do want you to think about it in terms of like this information is not to be used to like guilt or shame the mom. It's just a consideration of like all the sequelae. So it affects reactivity and attachment, and it has long-term effects in children. So these babies born to moms with depression or anxiety and having postpartum depression and anxiety can have long-term emotional problems, difficult temperaments, more behavioral challenges, reduced cognitive functioning, and lower IQ scores. And we're doing a lot of interesting data when it comes to looking at sort of the sequelae. So for example, for the Tutsi genocide, they looked at children born to moms who went through the Tutsi genocide, and they found in the fetal chromatin follow-up scenarios of effects on those babies, and they had reduced hippocampus sizes. In the fathers who went through, I'm forgetting the paper, it was I'll send the paper to Autumn later. They also found follow-through in spermal chromatin. They also found hippocampal sizes got smaller in rats that were exposed to sort of stress. And so the reason I'm bringing up this scenario is that it sounds really scary when you're like, all of these sequelae will happen. So when they stressed out these rats and had them give birth to their stressed out babies, then they gave those rats treatment, and treatment helped them return to normal, both for the mama rat and the baby rat. So that's a whole different conversation, which we can get into another time. So coming back to mood and anxiety disorders, Kathy Wisner is kind of like one of the pioneers of the field of reproductive psychiatry. And this quote always gets stuck in my head, and I want to make sure that you guys are thinking about it as well. Pregnant women get sick and sick women get pregnant. So in terms of pregnant women are at higher risk of depression and anxiety, and also people with depression, anxiety, bipolar disorders, schizophrenia are much higher likelihood of getting pregnant. So unintended pregnancy in subpopulations with psychiatric illness going from like that 48 to 50% in the regular population goes up to 60%, which is much higher consideration. So contraception has to be a conversation, regardless of when you're coming across a woman in her reproductive lifespan. The other thing that often happens is people will not choose adequate contraception methods. So there was this very interesting small little paper that looked at choice of contraceptive methodology for people with depression. And interestingly, people with depression picked more like shorter term options like withdrawal and condoms rather than things that are longer term, which is, I don't know how to explain that, but that's just what they found. So I think that conversation, if you guys are comfortable having, is something to have as well. So the other thing that happens all the time, and being a reproductive psychiatrist, bane of my existence, is I got pregnant, I went off the med. And here I am to see you. Great, I'm glad you're here to see me. But the other piece is there is a big difference in terms of relapse rate for patients who stay on medications versus who don't. What I will point out is people who stay on their medications, which is the blue line, will still relapse. And part of that is pregnancy physiology. So part of the endocrine system that I was talking about, one thing progesterone will do is rev up metabolism, and your liver system, your CYP enzymes that eat up every medication also rev up. Like the entire body is like, let me get rid of toxins, which interprets our medication as toxins. So the medication clearance increases. So sertraline at the beginning of pregnancy is going to get eaten up. So 40 to 50% increase in metabolism. So what's happening is if you're not adapting to that or responding or adjusting to that, automatically your medication dose is going lower, depending on the med, not every med, but that is also one of the hypotheses of why even people who maintain on medication will relapse. Also, as we discussed at the beginning, pregnancy ain't fun. And so that lack of funness can also contribute to a relapse. However, if you don't continue the medication, For those who discontinue, there is a significantly higher risk of relapse as well. So let's talk about sort of rules of engagement. Like, how do we consider perinatal mood and anxiety management? So this is the patient that's in front of you. This is the person that you're thinking of. Let's assume this person, this significant other, aunt, mom, yourself that you're thinking of has a mood and anxiety disorder. How would you manage them? You have two patients. No one patient is higher than the other. And it's not going to be like, I know that this one drug is great, so we're going to prescribe that one drug. That's not how it works. You have to pick based on the case. So based on what suits that person's lifestyle, what is their person's psychiatric history. So it's always going to be an individual collaborative decision. My job is not to be like, this is the right med, you take it. My job is to say, these are your medication options. These are the risks to those medication options. Do you understand the risks to the medication? Do you understand the risk to the disease? And what do you want to do? And how can I help you make a decision that's suitable for you? Because it's not that simple, right? Like, I'm not the one taking the risks on. And when it comes to risks, let's talk about that as we'll go through meds. It's important to kind of center. Every pregnancy has risk. So don't have depression, don't have anything, perfect, healthy person who's getting pregnant, they also have a risk of having major malformations happen in that pregnancy. And that baseline risk that we all take is 3 to 4%. So when you're looking at data, when you're looking at the Newsweek article that says Prozac causes autism, you are trying to say, is it higher than the general baseline risk? So if the general baseline risk of congenital malformations, baby with any malformations, is 3 to 4%, and it's going to say X med causes congenital malformations, is that risk higher than the general? If it is, okay, then let's figure out how well that study was done. Most of the time, some of those buzz articles will actually say the risk is 3.6%. That's still baseline risk. And so keeping that in mind in terms of how you're having that conversation, how you're interpreting the data. So that's the other pieces of perspective on risk I want to make sure that we all have. So the rate of malformations, major malformations, is about 3 to 4%. Rate of premature delivery, 11 to 12%. Rate of gestational diabetes, 2 to 7%. What's the rate of miscarriage? Anyone know? All right, about 18 to 20%, which is also important. But we'll talk about how studies are done, a whole another conversation. Part of the reason I'm bringing this up is because a lot of psychiatric data, especially reprosite data, is like Danish registries of 1 million women, Taiwanese, Korean registries. The problem with registry data is they are looking at what was reported, right? This person, I saw this number and it says they were on sertraline. Also, their diagnostic code in our database said depression, and then looks like we're following up the baby, no issues. That becomes a challenge when you're trying to study things like miscarriage, because those don't get reported. And so that's a bit of a big issue when it comes to looking at our data sets and interpreting it. And that's a big consideration that should be there at the back of your mind, is what are the limitations of the data that I'm reporting? So coming back to that in terms of risks of major malformation, something I want you to keep in mind, because as I talk about, as we get to specific meds, which given how well I've managed to pace myself, we may not get to specific meds, but we will get to general considerations. The risks of discontinuation is also another big one. So there are significantly higher rates of relapse, right? We talked about this, but how much higher? So those who discontinue antidepressant medications have about a 68% risk of a relapse of a depressive episode versus 26% of those who continue the antidepressant medications. When it comes to bipolar disorder, that risk is kind of ridiculous. 85% risk of relapse of bipolar disorder is a really, really high risk. And the disease is not without its impact on the pregnancy, impact on the mom, impact on the family. So that's a pretty decent consideration. But if you continue medication, that risk lowers to 37%. It's important to pause here and realize that people with psychiatric illness walking into pregnancy should be monitored closely, should have a continued follow-up throughout that, probably closer than what you're used to, because this is an unstable time for patients with psychiatric illness. And then anybody with a history of peripartum psychosis is basically very, very high risk for subsequent peripartum psychosis. Peripartum psychosis is also something that people don't talk about. The amount of patients who have come in and said, who have shown up for a peripartum psychotic episode, and then we've treated them, and then later go back and talk to their sisters or aunts, and they're like, two of my family members have this, and just people don't talk about it. The main things are so consideration is higher rates of relapse in pregnancy in general, more so if you discontinue. The other piece, when it comes to discontinuation data sets, the rate of discontinuation matters. So if you were tapered off, you're gonna delay sort of that relapse, and you're gonna have a lower risk of relapse. You go abruptly off, you're asking for a relapse. So making sure that if somebody's like, I want to come off, great, let's do it safely. And so coming off is also you have to do it managed well. A few things I want to make sure in terms of trauma, because as we take care of female birthing persons population, we're basically dealing with a population that has a very high risk of trauma anyways. So at least half of the women in the US will be exposed to one traumatic event. Of course, women are more vulnerable to sexual assault, childhood sexual abuse than men. And then 1 in 5 women in the US have been raped at some point. The reason I'm bringing up this is because in this time period, a few things happen, right? First, there is the history of trauma that you have that you're bringing into the pregnancy. Then pregnancy itself can be traumatic in terms of birth trauma, delivery being distressing, or something unexpected happening, stillbirth, miscarriage, etc. So pregnancy itself is traumatic as well. The other thing I want to bring up is that when it comes to people with a history of trauma, women are twice as likely to develop PTSD and to carry that diagnosis across their lifetime. When you're taking somebody who has a history of trauma or were abused during their childhood, pregnancy is a really weird space to be in, because then you have a response towards your child, whether it's something that you can't feel like whether it is I have no response or I have a very warm, loving response. Both of those are odd spaces to be in. And then to think back to the fact that you were a child and that warmth and love was not there for you, or even if you feel nothing towards this baby, it's very different than harming a child. And to really have to inhabit that space of my parent didn't care for me, I was set up to get abused, or when I did bring it up, this was a scenario that I had to deal with, that even if you have come to terms with your traumatic upbringing, there's a time that this can resurge and say, why wasn't I loved? Why wasn't I cared for? What was wrong with me? And even if I feel indifference, it's a very different thing from going from indifference to, assault. So trauma is something that will rear its head in pregnancy, in that postpartum period. And of course, that pregnancy period, you can also actually experience a lot more trauma. Intimate partner violence will spike during pregnancy as well. So that's something that should also be on your differential as you're working with patients. So on that lovely note, I'm going to switch to the most common group of medications, so SSRIs. This is your Prozac, your Lexapro, your Zoloft, your sertraline, so sort of that group of medications. This is that I'm going to talk about in terms of pregnancy safety. We have more data on the reproductive safety of SSRIs than most other meds. So I'm talking about pretty much not just psychiatric meds, other meds. So SSRIs are in some of the most studied category. What I want to do is make sure that you're thinking about the numbers of data of patients I'm talking. So as we talk about some of the meds, I'll bring up sort of the numbers in terms of how much data we have. Because when I say something like the most studied, it sounds impressive. But how impressive is it really? Cliffhanger, again, to keep you awake. So as we talk about reproductive safety of medication, I tend to, in my head, have 4 categories. Congenital malformations. Is this going to cause an issue to my baby in terms of heart defects, etc.? Gestational outcomes. Is it going to impact the pregnancy? So am I going to have preeclampsia, preterm birth, anything like that? Neonatal outcomes. Is something going to happen to the baby once the baby's born? So this is things like persistent pulmonary hypertension, neonatal adaptation syndrome, those kind of things. And then the last one, neurobehavioral outcomes. What do we know about the long-term sequelae of these medications to my baby? And I use that framing in my head because it just helps make sure I don't forget anything. I talk a little fast. And so that frame always just make sure that I didn't skip something as I'm talking to somebody who's coming to me for guidance about what to do for their baby and their pregnancy, right? Like informed consent is the cornerstone. And so let's talk about SSRIs in that framework. So in terms of congenital malformations, there have been repeated data sets on this in terms of SSRIs are considered safe. There's no increased risk of congenital malformation. That baseline risk of 3 to 4% does apply. There's one particular SSRI that we all look at with suspicion, and that one is Paxil. And so we'll talk about Paxil in a little bit, but in general, those are SSRI, the class is considered safe from congenital malformations. The other one with regards to gestational outcomes is a big one. So gestational outcomes are things like preterm birth, low birth weight. SSRIs cause low birth weight by about 6 ounces, actually 4 to 6 ounces. So technically, yes, significant from a research perspective, but not necessarily significant in every case. I have a sister-in-law who had a micropreemie. If I tried to tell her that she would have 4 to 6 ounce less baby with SSRI, she was like, no, do not touch me. Like, I've had a micropreemie, that's a big deal. So depending on the case, depending on the history, it's a really, really big deal. Additionally, SSRIs can cause preterm birth. Sounds scary. What do I mean by preterm birth? Which is where this is the joy of this is all in the details. Preterm birth, when you look at the research, is birth that is so the term of the pregnancy is shortened by 3 to 5 days, which is a pretty different thing than saying 3 to 5 weeks. So again, how much of a risk are you willing to take? What is acceptable to that patient? What is their history? What are they bringing into this pregnancy that they can absorb? Then neonatal outcomes. Neonatal outcomes, the other consideration is sort of the neonatal adaptation, which is going to happen in up to 30% of babies exposed to SSRIs. This is a very large spectrum of disease. So it can be anywhere from a fussy baby, which I don't know anything other than a fussy baby, so that 30% confuses me, to the very severe end of the spectrum, which is autonomic hypotension, sort of autonomic dysfunction. The autonomic dysfunction is about 3%. And most of the people are hanging out in that baby's fussy, baby wants to eat a lot, baby won't sleep well. And this is a very confusing sort of thing to be like, is this an issue or is this a normal spectrum of babies? So I can't really guide you on that. What I can say is that it's going to show up within 2 to 3 days of birth and it's going to be gone within 2 weeks. If it is not gone, it is not neonatal adaptation syndrome. That much we know for certain. And then the last one is neurobehavioral outcomes. So when it comes to neurobehavioral outcomes, this is why I wanted to make sure we thought about the numbers, because it's important to think about it when I say we have long-term data. So 13 prospective studies that have looked at neurobehavioral outcomes in utero with antidepressant exposure, 721 with antidepressant exposure. For those of you that live in research land, that's not a huge N to like hang my hat on, but that's the N I have, and it's way better than some of the other Ns I have. So it also matters how well the study is done. So when you look at some of the data studies, they're actually done really, really well. Some of the Prozac studies, gorgeously done. So when you look at sort of this review, 2014, no long-term behavioral effects. There are other data sets that are med specific. So as I said, Prozac data sets. They've followed these babies. They've looked at motor function, language, speech, long-term, like college, like up to 18 years, they followed Prozac babies. And so at that point, when they say Prozac is going to be safe for you long-term, they mean it. For what we do have, it's safe to say that there are no neurobehavioral infant outcomes that we're worried about that we attribute to SSRIs. Any questions? I'm going to pause here before I go into specific meds, and I'm going to do some highlighted meds. I'm not going to do every med because I don't think I have that much time.
We currently do not have any questions in the chat box, but if you do have a question or a comment, please feel free to put it in the chat box, and we'll make sure that Sarah gets that.
Okay. So I am going to take a minute to talk about Prozac, because Prozac is by far the most studied. And when I say by far the most studied, it's over 10,000 pregnancies reported to Prozac in the first trimester, which is quite a bit of pregnancies. And I want that framing for when if we get to talk about specific other meds. We have long-term data on Prozac babies. We have long-term cases that are saying there's no major congenital malformations. The other reason I want to talk about Prozac is because everybody's like, Prozac is safe. Yes, it is. But when it comes to breastfeeding, there's a little bit of a gentle pause on Prozac. The reason why is because when you look at the American Academy of Pediatrics, they recommend that anything under 10% transmission into breast milk considered safe. Prozac sits at about 12%. However, we don't recommend you stop breastfeeding in Prozac because we have a lot of babies that are Prozac babies, Prozac in utero babies, Prozac breastfed babies, and they do fine. And so Prozac tends to be one of those exceptions to keep in mind. So despite the higher level in breast milk, we tend not to recommend changing. So the other one that's everybody's favorite for some reason, okay, but I know why, is Zoloft. And so no increased risk of anomalies, no neurodevelopmental issues, very few neonatal side effects postpartum. So even that neonatal adaptation tends to happen less with sertraline. The things to keep in mind in sertraline is the most nauseating antidepressant on the market. It just is. which is not a pleasant experience to have when you're already struggling with nausea. And for those of you that have not struggled with nausea, go to San Diego, get on some of those whale watching tours, and see if you can survive that for 3 hours. And now imagine 9 months. Nausea sucks. Like, it's just uncomfortable, unpleasant, ruins your entire day. So please, for those of you that are taking care of patients, please take the nausea seriously, treat it, and then also help them manage that piece. It's just awful. Can't say enough about it. But sertraline is one of the most nauseating, so if you're going to start it, have them use it at night for the nausea piece. It's preferred in breast milk because that 12% of Prozac, sertraline is like 0.8%. So that's the other reason we tend to prefer it in breast milk. I'm going to talk about Paxil because Paxil had some great advertising when it came out. Like, everybody was using Paxil in the 90s. It was like hot. And then the problem became there was an FDA advisory, a caution about the use in pregnancy. So it got changed from, at the time, classification was the A, B, C, Ds. So it was a C, then it went to a D. And that was because there was an increased risk of cardiovascular malformations. There was a GSK-sponsored study that said it's only 1.5-fold increase, which, nobody wants to hear that. In the more recent data sets, where you're looking at sort of the mid-2000s data sets, it seems to be a bit more question of like, is it actually the Paxil, or is there some confounding factors in those bigger studies that weren't taken into account? Which I don't really know. I mean, you could get convinced by it, but given all that it has and all the Google searches it results in, I tend not to reach for a Paxil. And in the scenario that I have to, which I have taken pregnant people through Paxil pregnancies, I tend to go to the Berard study. It was a smaller study out of Quebec, and that associated it with a dose-dependent relationship. And they felt like Paxil doses above 25 milligrams were associated with major malformations. However, those under were not. And so this is something to keep in mind in terms of how you are discussing Paxil, who's been on Paxil. You can do it, but you have to make sure you've considered the informed consent. The patient knows what they're willing to do, because it's up to the mom and what they're willing to accept in terms of risk. It's a great med in the postpartum scenario because, again, very low transmission in the breast milk, and it doesn't really cause any issues. The one thing I will pause here is when I say meta-analysis in Paxil breastfed infants, we're talking about 37 infants. So the data sets and the volume and the numbers are different when it comes to pregnancy versus breastfeeding. So we have much, much lower symptoms. I do want to talk about autism for a second, because this is another thing that we're like, SSRIs cause autism. That was not a good Newsweek article. I had so many calls that week. These were early studies, had a lot of confounding factors in terms of showing an association between SSRI use in pregnancy and autism spectrum disorder in offspring. Since then, we've done more careful studies, sibling control studies, propensity matching studies. Propensity matching studies are important because we can't always, in the real world, sort of create the fair control. So propensity matching studies will help you create a matched control so that you can control for these confounding factors. So in those, we found that there is no increased risk. There was one study that I have on the slide that found a slight increased risk in autism spectrum after antidepressant exposure. So if we're to neglect everything else that's said with sibling control and propensity matching that says it doesn't increase the risk, and we say this smaller study, which was well done, is the right study, then stopping antidepressant use would reduce the risk of autism by 0.08%. So thinking about it in terms of how would apply to your patient and how that would work. In general, risk of autism is higher in women with psychiatric disorders who do not use SSRIs than in women who do. That's just a data finding. In terms of explaining it, I got nothing. There was a bunch of hypotheses people had, but I don't really have anything. We already talked about neonatal exposure and side effects in general, so I talked about this already, so I'm going to skip forward. I'm not going to get into the other antidepressants because I don't think we have that much time. How much time do I have?
You have 11 minutes.
I have 11 minutes. So what I'm going to do is I'm going to pick an antidepressant that I want to make sure that I talk about, and that's mirtazapine. And part of the reason I'm picking mirtazapine is I think it's an oldie but a goodie. Like, it's a great med. It works really well. It's got good data sets when it comes to mood and anxiety disorders. We don't tend to reach for it a lot. We don't tend to reach for it a lot because it causes weight gain. And it's not a little bit of weight gain. It's about 20 to 30 pounds of weight gain. So of course, females, we don't tend to think about it. The reason I'm bringing it up is because it has anti-nausea effects. So it hits the same receptor as Zofran on ondansetron does. And for those of you that don't know Zofran or ondansetron, it's the one med, the primary med that we'll use in like cancer patients for chemotherapy. It's the same receptor. So it does really well as an anti-nausea medication, which is something to keep in mind. And it makes you hungry. So for people who are struggling with hyperemesis gravidarum, real severe nausea, it's a great option. It comes as an oral dissolving tablet. So keep that in mind and make sure that you're discussing it with your patients as well. We also got new data on mirtazapine. So it's been around a while, this med. So it's nice when you get new data on old meds because yes. And so the new data was 2022. It was a Danish register based. And so they found that there was no association between mirtazapine exposure and major congenital malformations, no increased risk of spontaneous abortion, no increased risk of stillbirth, no increased risk of neonatal death. The reason I'm also putting it up is because it's been around a while, and that's the data sets we have, which I'm very grateful for. But again, doesn't say anything about long-term neurobehavioral effects, etc. So that's something I want to keep in mind. Also, mirtazapine is a good option for breastfeeding because it's got very low serum levels, which we don't have that data on on most meds. So if you have patients, please ask them to sign up for like the MGH studies or sign up on whatever local studies you're aware of so that we can get data, things like, maternal serum level, breast milk level, infant serum level. Very important for us to have, but we don't have it. Mirtazapine, been around for at least 20, 30 years. I have a case study of 8 infants. So low data when you think about it. I'm going to skip over Wellbutrin and tricyclics. And I want to talk just for a second about brexanolone. This is kind of hot in the press now. The new med is the I can't pronounce it, Zurzuvae, something like that. So brexanolone was its parent drug. It was released in 2019. It's cool and for the nerd in me because it's a unique mechanism of action. We've been dealing with the same mechanism of actions for years. This one is it's an IV-derived analog of allopregnanolone. So what happens in pregnancy is allopregnanolone levels are high, and in the postpartum in 6 weeks, they kind of drop. And so Sage Therapeutics was like, maybe this is why you get depressed. And so we're gonna come up with this. The parent drug, the sister drug, the proof of concept drug, whatever you want to call it, brexanolone, didn't work out well. Came out in 2019, so not a great timing. Has to be 6 days of like IV in the hospital because people got really, really sedated on it. And then again, it was like $35,000 to implement, so to get a dose, which is not great either. So then they came up with a oral form, which is the one that's making the headlines. This is the Zurzuvae. And so I'm hopeful to see how that's going to kind of roll out. So I know that it's going to be kind of dispensed with specialty pharmacies. We don't really know how much it's going to cost yet, which is what we're kind of hoping for. And the other thing is it seems to hit the same receptors as benzos. So that's also going to be interesting to figure out in the implementation of it. But it is, to the nerd in me, it's a new mechanism of action. We're looking at a disease in a new way, which is very, very important because we can't just be like serotonin the entire time. A few other things I want to make sure we think about is you're working with this person that's in your head. Please maximize social supports in terms of like coming to check in, talking about family, psychoeducation of patients and family members. That factor about parents of paternal depression is a big one. Bring it up. Make sure the significant other knows they're also at risk because sometimes looking at it as a team-based approach towards care, we're both in it together. Meet mom and dad. We're going to take care of this baby. We're going to take care of mom. We're going to make sure dad doesn't get well. Much better space to be in rather than let's all support her. So I think helps everybody get on board. And then think about group therapy, support groups, Postpartum Support International, especially the Arizona chapter has a bunch of resources on their page. So they'll know, you can call them, their volunteers will let you know in terms of like local resources as well. Omega-3 fatty acids, small benefit in sort of parent episodes, but not exactly that dramatic, but helpful, especially if your patient is like, I want to make sure that I'm going off of drugs, I don't want to take a risk. The one thing I will say, and nobody likes me for saying this, exercise. When you look at exercise as a prescription, exercise will, as a prescription, so the prescription of exercise would be 3 to 4 days a week of 30 minutes of exercise, has double the effect size of an antidepressant. Now you're pregnant and you don't want to, and I understand all of that. But if you're going to work with your patient, I think looking at it in terms of prescription of exercise, and this is actually going to be something we prescribe you and you're going to do it. because we don't want to take the risk of you getting depressed. So it's not just going to be, I'm going to park a little farther away, which is also great, but like making sure how you're asking them. Because in the studies, you can't adhere to the protocol. Light therapy works, but you have to think about the actual idea of like it's designed for seasonal affective disorder, unipolar depression. So again, it's a dose-based thing, 30 minutes exposure within a few feet of yourself. So where are you going to put it? How are you actually going to get the right dose? I am going to pause here. Actually, no, I'm not going to pause here. I'm going to talk about the Arizona Perinatal Psychiatry Access Line because people keep telling me I forget to talk about it. So we in Arizona are the 20th in the US. So what we do, which I run, is anybody in Arizona who's taking care of pregnant postpartum patient can call us and say, I want to discuss the reproductive safety of this medication. What are my options? How do I take care of this person? We'll do case consultations for free and we'll come and train for free. And so if you want to call, you'll either get me or my co-director, who's brilliant, Dr. Catherine Emmerich. That's our phone number. We are available Monday to Friday, 8:30 to 4:30. It is not direct patient care. I'm trying. We'll get there. But right now we are able to kind of do clinical consultations on the phone. So it's been really nice. And honestly, I could tell you some cases that have been really rewarding to work with. The other thing that's on the horizon for us is we're trying to launch a pediatric psychiatry access line, same thing for child psych. And hopefully we should have that launched within a few months if things work out. We have resources on our page, including a map of Arizona. So you can kind of click through county-based map and we'll have county-based resources on there. And for those of you that are like, this wasn't enough, I want to learn more. Mother to Baby is a very good resource for you and for your moms. Infant Risk is a big one, Uber Talks, Lact Med. And then if you're really excited about getting like a blog post, MGH runs a great blog. I highly recommend them. And then PSI does trainings. And now I'm going to stop talking.
Okay, we're opening up. Before Don does a recap, just one question maybe.